Hello, I'm Gregg Stone from Columbia University Medical Center and the Cardiovascular Research Foundation in New York. And today we're going to talk about the important emerging role of physiologic lesion assessment after PCI. And I think everybody is very familiar with the well-established concept now of the necessity, importance to measure physiologic lesion assessment before PCI. So lesions that are physiologically significant obviously are associated with angina, reduced quality of life, and even have been associated in many studies with a risk of death and myocardial infarction. And we have great studies from FAME1, FAME2, and other investigations on the fact that those are the lesions principally we should be targeting with revascularization, particularly with PCI. But a new and emerging concept is that of post-PCI physiologic assessment, which was first done, of course, with stress testing, then with FFR, and now with emerging new data from the DEFINE PCI study with a resting indice, and that is IFR. So to help me with this discussion today, I'm thrilled to have three friends and colleagues: Manesh Patel from Duke University, Habib Samady from Emory, and Alan Jeremias, my partner at St. Francis and the Cardiovascular Research Foundation. And Alan has recently led the DEFINE PCI study, which you're going to be hearing about during this webcast. So first, though, let's talk about the background and the importance of physiologic lesion assessment post-PCI, and what is the clinical problem that we're trying to tackle with this.
Thanks,
Mahesh?
Greg. I mean, you know, one of the things people, and I think you've highlighted for us before, is that we've had a lot of innovations with angioplasty over the years, you know, from bare metal stents to drug-eluting stents to actually physiologically driven FAME1 and FAME2. And on this slide, you'll see that throughout those times, unfortunately, there remains angina after PCI at 1 year. And so one of the things, of course, that we do with elective PCI is to try to make patients feel better. And even after accomplishing that in the cath lab, we have patients that somewhere between 30 and 20% sometimes will have angina at 1 year. So that's the clinical problem, if you will, that we're trying to solve. And one might say, well, is that due to residual ischemia? As you highlighted, there's stress testing we used to do, and then we use physiologic guidance. So there is some data, of course, that residual ischemia after PCI is not uncommon, even when you measure it using FFR, as done sometimes up to 10 to 20% of the time. And so if you have residual ischemia, and then you have angina, is that related, as you said, to adverse events? And there's data from FFR post-stent registry that I think many were involved in that shows that, in fact, when you have some residual ischemia after stenting patients, as defined by not normal physiology in that vessel, you have up to, again, 15, 20% of those patients having events.
Right.
So this is an opportunity potentially to change that outcome.
And that's not surprising. I mean, the FAME2 study showed us that if you don't treat physiologically significant ischemia or lesions related to ischemia, that you have a high rate of events, both urgent and elective revascularization, as well as myocardial infarction occurring late.
Yeah, and I think you know, so the target for us is, as we continue to refine and think about how do we make patients feel better, is there something we could be doing in the cath lab to make them feel better? And so there's a signal to say, if there is pressure loss that's still in that vessel, can we make them feel better?
Right. So Habib, there may be many different reasons for angina after a PCI procedure or after CABG, and there may be other causes other than just residual ischemia in the target vessel. Can you enlighten us to what some of those causes might be?
Sure, absolutely. So as you point out, sometimes ischemia may end up being microvascular. We know that that happens, but a lot of times there's residual ischemia within the vessel, and you end up spot stenting a certain area that angiographically you think is the problem.
Right.
And what we're learning from doing detailed physiological studies over the years is that, in fact, we often get that spot wrong in the cath lab when we use angiography. And so the opportunity for us with the new technology, and particularly IFR that Alan's going to talk about now, is that we're going to be able to pinpoint where the ischemia is so you can target it. But before we do that, we need to understand that when people use their current methodology of PCI, do they leave behind ischemia, and where is the ischemia? Do you leave it behind in the stent, or did you just miss the spot? So
and
I think
it's really, you bring up such a great point. It's amazing to me that I think most people, at least in the United States, and I think in Europe and other places, still guide their PCI primarily by the angiogram. And it is such a tarnished gold standard. There's often severe atherosclerosis and plaque that you can't see in lesions that you don't even touch. Other severe lesions are not as bad as you think they are. And of course, you know, when you put in a stent, there may be unresolved stent edge issues or even unexpanded stents that you just can't appreciate angiographically, but most people don't look. And the classic way we've looked is with intravascular imaging, but now we're getting some exciting emerging data about post-PCI physiology. Again, initially with FFR, but now with IFR.